Okay, here we are. Okay, so we're going to begin like we did on Wednesday with the solid tumor rules. So what I did here is download a PDF version of the malignant CNS solid tumor modules. And as we go through, you will see where I've entered some text boxes in red font, and those are just to show you how the malignant solid tumor rules differ from the non-malignant solid tumor rules. I kind of had it in my mind that maybe we could combine both of those sets of rules together in one presentation, as long as you remain aware that they are two separate sets of rules. So if you have a malignant tumor, be sure to use the malignant CNS solid tumor rules, and non-malignant, use the non-malignant set of solid tumor rules. So our primary sites included in the malignant solid tumor rules are your peripheral nerve sites, the meningeal sites, spinal cord sites, the brain sites, and I want to stress for solid tumor rules, the brain sites include 710 through C719. So the meninges and the spinal sites and the cranial nerve sites are considered separate from the brain. So also included in these is the, along with the spinal sites, is the cauda equina C721. And then we have our cranial nerve sites, which is C722 through 25. And then our intracranial gland sites include pituitary, craniopharyngeal duct, and pineal gland, site C751 through 53, respectively. And then, of course, just our general NOS, the C728 nervous system overlapping, and C729 nervous system NOS. So as stated previously on Wednesday, the timing for these rules is for cases diagnosed 1/1/18 going forward. And in the case if you have multiple tumors, maybe one that was diagnosed prior to 1/1/18, and then another tumor is identified after 1/1/18, and you need to make a decision. Is this new tumor a new primary or not? And I'll give you an example. If the new tumor is diagnosed 1/1/18 or after, you would need to apply these rules. And the example is if you have a meningioma of the left cerebral meninges that was diagnosed in 2016, and then a new meningioma of the right cerebral meninges was diagnosed in 2018. You would need to apply these 2018 rules to this new tumor to determine if you have a new primary. Now, by applying these new rules, the meningioma identified in 2018 would not be a new primary, because per the 2018 rules, laterality does not determine multiple primaries. Okay, now for using these rules, the malignant CNS tumors, you must have a histologic, cytologic, radiographic, or clinical diagnosis of a malignant neoplasm, behavior of 3. I did, and then for the head and neck rules, for the paragangliomas in the head and neck sites, you do use the head and neck rules and not these rules. Now, for these sites, we do not code multiple primaries based on biomarkers, but we do use biomarkers for identifying histologies, and you will see that later. Now, as I mentioned before, I have entered text boxes here to indicate how the non-malignant rules differ from the malignant rules. And I'm really not going to point those out very much, but I do just want to point something out here in regard to one of our histologies that is new. The histology for pilocytic astrocytoma, which is 9421, we have been instructed previously to code those with the behavior of 3. We will continue to code those with a behavior of 3 if the primary site is a brain site, C710 through C719. However, if the primary site is a cranial nerve site, and most often you will see these as the optic nerve, then the behavior is coded as 1. Equivalent terms and with are synonymous for describing multiple histologies within a single tumor. Dura and meninges are equivalent. Extradural is not within the meninges, within the cranium, within the skull, but not within the cerebral meninges. Extramedullary is outside the medulla oblongata. Intradural is between layers of the cerebral meninges. Intradural extramedullary is within the spinal canal, but outside of the nerves. Intraspinal is occurring within the spinal column, especially the vertebral canal and the spinal nerve roots. The cerebrum contains the frontal lobe, the parietal lobe, the occipital lobe, and the temporal lobe. These are supratentorial sites. The tentorium is pretty much the landmark in the brain that separates the supratentorial sites from the infratentorial sites, and we'll go into that a little bit more later. Tumor, mass, lesion, neoplasm are equivalent terms only for determining multiple primaries. You do not use these terms for case finding or determining reportability. Now, this is particularly important when you're determining reportability for your non-malignant tumors. Your non-malignant CNS tumors will only be reported if described as one of the reportable histologies, or if you do not have the available reportable histology, then only reportable if described as tumor or neoplasm, and that is in the SEER manual. Type, subtype, and variant are equivalent. WHO grade 3 and WHO grade 4 are equivalent with malignant, invasive, and a behavior of 3. Terms that are not equivalent. Component is not equivalent to subtype, type, or variant. Component is only coded when the pathologist specifies the component as a second carcinoma. Phenotype is not equivalent to subtype, type, or variant. WHO grade is not equivalent to tumor grade. The WHO grade is a malignancy scale that assesses the aggressiveness of the tumor and the likelihood that it is to recur, whereas the tumor grade is determined microscopically and defined as differentiation. Changes from the 2007 rules. Gliomatosis cerebri is a term which is no longer recommended. Gliomatosis cerebri is now termed a growth pattern rather than a histologic type. The term glioma. The term glioma is an umbrella term for all gliomas and astrocytomas. Glioma, NOS, is not recommended because diagnostic methodology is able to determine a more specific diagnosis. So you're not going to see the histology for glioma, NOS, in our histology table in these rules. A major change from the 2007 rules is that now a glioblastoma multiform subsequent to an astrocytic or gliotumor is a multiple primary. Glioblastoma multiform is now being collected as a new primary, so it is possible to analyze the frequency with which these tumors recur in a more aggressive form. Clarifications. The following meningiomas are reportable: intraosseous, cavernous sinus, and sphenoid wing. Multiple cerebral meningiomas are a single primary. Multiple brain tumors, and I want to reiterate 710 through C719 are a single primary. Laterality is not used to determine multiple primaries. Timing is not used to determine multiple primaries. The brain, C710 through C719, is a single primary site. Neurofibromatosis and its subtypes NF1 and NF2 and schwannomatosis are genetic syndromes and not reportable neoplasms. So you would not report these conditions as reportable neoplasms. However, if you have a reportable tumor within the condition, you would report the tumor. When we take a look at the histology table, you will notice that the new codes and terms are identified by asterisks, and I believe that we have 4 new histologies. Reportability criteria. CNS neoplasms must meet all three conditions to be reported as malignant. The behavior must be malignant/3. The pathology designates the behavior as malignant, or the tumor is a WHO grade 3 or 4. Now, WHO grade 2 tumors may be non-malignant or malignant, so you will have to assign the code as designated by the pathologist. Never report a malignant/3 behavior code for a meningioma based on tumor extension to brain, skin of scalp, or other regional organs. Non-malignant CNS tumors can extend to the regional tissue and bone. The primary site must be reportable and the histology must be reportable, and we have tables for those that you will see shortly. So here is our directory of sections and tables, and we'll just go through those. Section 1, behavior code. Similarly, what we discussed on Wednesday, the instructions for documentation here are in priority order. So just like you do when you go through the rules, you will stop at the first instruction that applies to your scenario. So the priority for using documentation to assign behavior is first is the pathology from the resection. Use the pathologist's description of malignant or invasive behavior. And remember that WHO grade 3 or 4 is malignant. Never change behavior described by the pathologist. Second in priority is the pathology from the biopsy. Next is cytology. And then next is the physician documentation in the following priority order. First is tumor board. Then next is the physician documentation of the original pathologic diagnosis and behavior. And then next would be the documentation of the behavior if there's no mention of the original diagnosis. Next in priority is your imaging studies, and the imaging studies are in priority order of MRI, CT, PET, and angiogram. When none of those instructions apply in determining your behavior, use Table 1. Table 1 is the table of WHO grades, which I explained before is a malignancy scale. All WHO grade 1s are non-malignant. WHO grade 2 can be malignant or non-malignant. So you would need to go through your rules that we just discussed earlier. And if they do not apply, if none of the rules apply, then you need to either follow back with your pathologist or your registry advisor. And this table is very helpful, and it shows all of our tumor types and their corresponding WHO grades. This table is also in the AJCC manual. I think it would have been a little more helpful too on this table if they had indicated the histology code as well as the histology name to help you with that. But that is here, and it's a valuable reference, particularly if you only have a clinical diagnosis, say from imaging. If you have a clinical diagnosis, you can code the WHO grade. If you know the specific tumor type as stated in this table, you can code that WHO grade in grade clinical. Remember though, however, you can only code a grade in the pathological grade field if a resection has been done. And there's all your histologies. Okay, moving on to step 2, our reportable primary sites and histology. So after you have determined that your behavior code, the next step is to confirm that both the primary site and the histology are reportable. Peripheral nerves are extracranial or extradural. Extracranial is outside the cranium and extradural is outside the spinal duras. Now, this is particularly important for your non-malignant central nervous system tumors, because once a tumor is exited the cranium or the spinal cord and assumes the primary site of peripheral nerve or any structure outside the central nervous system, it is not reportable if it is a behavior of /1 or /0. Non-report behavior /1 or /0 tumors are only reportable if they are within the central nervous system. Cavernous sinus is located between the endosteal and meningeal layers of the dura. There is no ICD-10 site code for cavernous sinus because tumors do not arise in the sinus themselves. They either arise in the cranial nerves that pass through the sinus, for example, C725, or the cerebral meninges that covers the cranial nerve, C700. Priority for coding primary site. Always check the op report, which will have information on whether the surgery or biopsy was intracranial or intraspinal. Again, the list is in hierarchical order. First in priority is the op report and then the path report from the resection, then the op report, then the path report from the biopsy. Third in priority, if a resection and or biopsy was performed, but the op and path report are not available, you would use the information from first, the tumor board, second, from the physician documentation of the original diagnosis from the op or path report, or the physician's documentation of primary site in the medical record. Next in priority for cases that have no pathology is imaging in priority order of MRI, CT, PET, or angiogram. And then you can see the reportable primary site table to confirm that the primary site is reportable. And like I mentioned before, this is particularly important for your non-malignant CNS sites. And then we also have a separate table, table 4, for malignant tumors of cranial nerves versus peripheral nerves. So the 3 reportable primary site groups for malignant CNS and peripheral nerves are intracranial within the skull or cranium and spinal sites within the spinal meninges and sites within the spinal meninges and peripheral nerves. Our 3 layers of the meninges are the dura mater, which is the layer closest to the skull, the arachnoid mater, which is the middle layer, and the pia mater, which is the layer closest to the brain. These are all included within your C700 series. Our brain sites are C710 through C719. Our cranial nerves are C722 through C729. Remember, C721, cauda equina, is included in the spinal sites. And then our intracranial glands, C751 through 53. And here we have a description of our spinal sites and our peripheral nerve sites, our C47s. Now here is our table of reportable primary sites. We have our brain, cranial nerves, ill-defined, which is your C728 and C729, our intracranial ducts and glands, meninges, peripheral nerves, and spinal sites. Okay, so moving on to our next section, our histology. And here, the histology table, it appears in similar fashion to the tables in all the other sets of rules. Our specific and NOS histology is column 1. Our synonyms is column 2. The synonyms have the same histology as the NOS histologies in the first column, and our subtype variants histologies in the third column, which have different histologies from their corresponding NOS histologies in column 1. And as I noted previously, the histologies that have asterisks on them are new histologies. So here we see in our glioblastomas, we have a new code 9445 for glioblastoma IDH mutant. And then there are 3 new histologies that are subtype variants of medulloblastoma NOS. And I used the other day our example of sarcoma to show that an NOS histology can appear in the NOS column as well as in the subtype variant column. And you see that here again with sarcoma. You see that chondrosarcoma and leiomyosarcoma appear both in the NOS column as well as in the subtype variant column. That is because chondrosarcoma and leiomyosarcoma are both subtype variants of sarcoma NOS, and leiomyosarcoma and chondrosarcoma are NOS histologies because they have subtype variants of their own, which you see indented underneath them in the subtype variant column. And then moving on to coding primary site for malignant tumors of cranial and peripheral nerves, we have a table here that goes into great detail of giving you instructions of when you would code your primary site to the cranial nerve versus the peripheral nerve, and at what point the tumor would exit the cranium and become a peripheral nerve site as to opposed to a cranial nerve site. So there's a lot of detail here, and I will leave review of this table to yourselves, as it would take a great deal of time to go through it. And just remember, once the tumor exits the cranium and becomes extracranial and a peripheral nerve site, it would have to have a behavior of 3 in order to be reportable. Okay. And then this is just some additional information to complete your abstract. Occasionally there are instances where you have discrepancies in primary site or histology or behavior. So when possible, get advice from the pathologist, from the attending physician, or from the registry advisor. If none of those options are available, code the histology and behavior from the most dependable source. So we've gone through all the instructions and their priority that would guide you in making those decisions. Here is our table of paired sites. These sites in this table are sites for which laterality is required. Now, SEER allows you to code laterality for sites where laterality is not required, but these sites, the laterality must be coded. This table is benign borderline malignancies in the first column that have the potential to transform to malignant behaviors. Now, when we go through the rules, you will see that a single tumor is always a single primary. However, we are going to have one exception to that rule in regard to glioblastoma multiforme, which you will see shortly. So as far as my understanding is if you have one of these non-malignant tumors that transforms to a malignant tumor, it would still be a single primary, but you would update the behavior to 3. And I believe the timing would be irrelevant. However, if it has been quite a large amount of time that has progressed for this transformation, I think you should submit a question to ask a SEER registrar to help you make the accurate decision as to whether or not you have a new primary, because there's always going to be some exceptions to the rules, and that's what Ask a SEER Registrar is for. So here we have our diagrams of the brain and central nervous system, as well as the spinal cord, and you can review those on your own. And we're going to move now into our multiple primary rules. So just remember that the non-malignant tumors have a separate set of rules. Laterality is not used to determine multiple primaries, and timing is not used to determine multiple primaries. A glioblastoma multiforme following an astrocytic or glial tumor is a multiple primary. These rules are not used for tumors described as METs. And then I've already gone over the timing and the scenario for when you have multiple tumors where one is diagnosed in earlier years and one is diagnosed in the time frame for using these rules. So if we have the situation where it's unknown if single or multiple tumors, M1 abstract a single primary when not possible to determine if single or multiple tumors. Our rules for single tumors: M2 abstract a single primary when there is a single tumor. M3, a single primary, code a single primary when a neoplasm is originally diagnosed as an oligodendroglioma and subsequently recurs in residual tumor tissue with different features, such as a densely cellular tumor with pseudo-palisading necrosis. M4, abstract a single primary, the malignant primary, when a single tumor meets the following two criteria. The original diagnosis was non-malignant, behavior 0 or 1, and first course treatment was active surveillance. There was no tumor resection as first course treatment. The diagnosis was clinical, radiographic, or by stereotactic biopsy. And then the subsequent resection pathology is malignant. This is a new rule which clarifies that a single tumor is always a single primary, and the malignant behavior is reported. The resection pathology is more accurate than your clinical, radiographic, or stereotactic biopsy. Now, while the stereotactic biopsy provides a pathologic specimen, it is small and may not have included the malignant portion of the tumor. There is no time requirement from initial diagnosis to resection. So if you have already abstracted this case as a non-malignant tumor, you would keep the diagnosis date the same, but you would update your behavior to 3, as well as notifying the central registry of the changes. So moving on to the multiple tumor rules, separate non-contiguous tumors are always multiple primaries when in the central nervous system and in a site other than the central nervous system, and in different central nervous system sites. You will see that with Rule 8. M5, abstract multiple primaries when there are multiple CNS tumors, one of which is malignant and the other is non-malignant. The original non-malignant tumor can be followed by a malignant tumor. The patient had a resection of the malignant tumor, not the same tumor, or it is unknown or not documented if the patient had a resection. Simultaneous non-malignant and malignant tumors, you would abstract both the malignant and the non-malignant tumors. A non-malignant CNS tumor and a malignant CNS tumor are always multiple primaries. Timing and primary sites are irrelevant. You will prepare 2 abstracts. Now, the major difference between M4 and M5 is that M4, there is no resection as first course treatment, and it is the same tumor. When the same tumor is subsequently resected, the pathology proves malignant behavior. M5, we're talking about separate tumors, and the tumor is resected as first course of treatment. M6, abstract multiple primaries when a patient has a glial tumor and is subsequently diagnosed with a glioblastoma multiforme. This is going to be our exception to a single tumor is always a single primary. We had a case at the Central Registry where a single tumor transformed to a glioblastoma multiforme, and I did send a question to SEER about this, and they said, we do want you to abstract this as multiple primaries because the standard setters and researchers are wanting to see the tumors that transform to glioblastoma, and also to see what non-malignant borderline tumor cell types are transforming to glioblastoma multiforme. So this is going to be our single exception to a single tumor is always a single primary. M7, abstract a single primary when there are separate tumors in the brain with the same histology. Now, I want to clarify tumors in the brain, C710 through C719. Wink, wink, you'll see this later. Tumors may be any of the following combinations: in the same lobe, in different lateralities of the same lobe, in different lobes. Most malignant neoplasms are single tumors, with some exceptions. And in these notes here, which I'm not going to go over there, you can look at those on your own. But these are, they name some of the tumors here that can, malignant tumors that can appear as multifocal. So this is a change in the clarification from previous rules. M8. Now notice M8, abstract multiple primaries when multiple tumors are present in any of the following sites or subsites. Any lobe of the brain, C710 through C719, and any other part of the central nervous system. And then I'm not going to list all these, but they give you the examples of when you have a tumor in the brain and then a tumor in, say, for example, the meninges. They would be separate primaries. So you can have a situation in M, like we had in M7, where you have 2 tumors that have the same histology. They would be multiple primaries due to M8 if they occur in the brain or any other part of the central nervous system, or 2 separate subsites of the central nervous system. And they're all listed here for you. M9, abstract multiple primaries when separate tumors are 2 or more subtype variants. We have that rule in other solid tumor rules of the other primary sites. M10, single primary when histologies are on the same row. We've seen that rule before. Same row means they can be the same histology. A synonym of the NOS code or a subtype variant of the NOS code. M11 multiple primaries when on different rows, you've seen that rule before, and M12 abstract a single primary when tumors do not meet any of the above criteria. So if you've gotten to M12, make another pass through the rules and make sure you have not skipped a rule that applies to your scenario. So moving on to histologies. Code the histology prior to neoadjuvant treatment. Code the histology assigned by the physician. Do not change histology in order to make the case applicable to staging. Hierarchical list of source documentation. Pathology from resection of the primary tumor. Priority is given to biomarkers now for histology. Biomarkers are emerging as an important factor for determining histology, so that's why it's listed here above priority in addendum, final diagnosis, and CAT protocol. Second in priority is your pathology from the biopsy. Again, the same priority with the biomarkers, the addendum, the final diagnosis, and CAT protocol. Next in priority is cytology, then pathology from a metastatic site, and then scans in priority order, MRI, CT, PET, and angiogram. And last in priority is the histology documented by the physician when none of the above are available. In priority order of first the treatment plan, then the tumor board documentation, then documentation in the medical record that refers to the original pathology, cytology, or scans, and then lastly, the physician's reference to the type of histology in the medical record. The priority is to code the most specific histology. The most specific histology can be described as majority or predominant part of tumor, minority of tumor, or a component. Do not code histology described as differentiation or features of, code the histology described as differentiation, features of, only when there's a specific code using those terms. Code the specific histology described by ambiguous terms only when A or B is true. A, the only diagnosis available is one histology term described by ambiguous terminology. Now, I want to give you an example here. Say you only have a case where you only have imaging. In the imaging states, tumor is suspicious for a head and neck squamous cell carcinoma. And you don't have any pathology. That's the only thing that you have. So you will accession the case with the histology documented as squamous cell carcinoma. Now, here's another example, and we've seen this a whole bunch. Say, for example, you have a lung pathology case, and the pathology final diagnosis is non-small cell carcinoma compatible with squamous cell carcinoma. You should code that as non-small cell carcinoma. You would only use the histology described by the ambiguous term here if the physician confirmed the histology described by the ambiguous term, or the patient is receiving treatment based on the specific histology described by ambiguous term. So this has been the hardest thing for registrars to unlearn. You do not code a histology described by ambiguous terms unless it's the only thing you have in the medical record or confirmed by the physician or the patient's treatment. In here, we see our list of reportable ambiguous terms. And then our last instruction for histology: do not code histology when described as architecture, foci, focus, focal, or pattern. So moving on to our H rule, our rules for single tumor, code H1, you will code only the reportable tumor when patients have genetic conditions such as neurofibromatosis and their subsites of NF1, NF2, or schwannomatosis. The conditions themselves are not reportable, only the reportable tumors within those conditions. H2, code malignant meningioma 9530 when the diagnosis specifically states malignant. So you do not code a meningioma as malignant if you have a description of invasion of brain or skull or skin, as non-malignant CNS tumors can extend to neighboring structures. The meningioma has to be specifically stated as malignant to code with a behavior of 3. H3, code the histology when one histology is present. And I demonstrated for you Wednesday, the priority documentation is the documentation, the histologies in the charts from the solid tumor rules. If your histology is not found there or within the rules, then your next priority order is from the ICD-03 implementation documentation from the NACER website, and I'm not going to demonstrate that today. If you do need it demonstrated, just put a request in the Q&A, and if we have time later, I will demonstrate that again. And if not found in the ICD-03 documentation, then you would go to your ICD-03 manual, and if not found in the manual, submit a question to ask a SEER registrar, and the link is here as well as on the SEER website. So moving on to H4, code the subtype variant when there is an NOS and a single subtype variant of that NOS. And here are several examples for you to review on your own. The rules for multiple tumors abstracted as a single primary, H5. Again, our same rule regarding meningioma. When you have multiple meningiomas, you only record that as malignant if specifically stated as malignant. H6, code the histology when one histology is present in all tumors. H7, code the subtype variant when all tumors or an NOS and a single subtype variant of that NOS occurs. So here are several examples again for you to review on your own. So that concludes our walkthrough of the solid tumor rules. Do we have any questions before we proceed through the rest of the presentation?
I do not see any questions.
Okay, then on to the rest of our data items that we're going to be looking at, which include the SSDIs, extent of disease, and summary stage. So here is a listing of the primary sites and schemas, and I demonstrated for you on Wednesday the SEER RSA and how you determine what schemas to use for what primary sites. So a lot of these are histology dependent, so you just need to search your schema primary sites, and then when you get there, be sure you're reading the notes to make sure you're in the appropriate schema. Our SSDIs, starting with grade. We talked about this, and not a lot different from our process of looking at the grade clinical, pathological, and post-therapy in the urinary sites. Our grade clinical cannot be blank. We assign the highest grade during the clinical time frame. If only one grade is assigned and unknown, if clinical, pathological, or post-therapy, assign as clinical. The peripheral nerves have a priority grading system, grade 1 through 3, based on mitotic count and necrosis score. Or they have the A through D categories available on their grade tables. This also means because they have the A through D categories, you can map using the generic grade tables from the SSDI manual, which if you need me to demonstrate that later, I will do that. After the presentation, you can submit a request in the Q&A. You can access the grade manual on the NACER website, and then browse the table of contents for the generic grade system, and then you will find how you can map terminology to a grade of A through D. Our grading system for the intracranial gland, brain, and CNS other all use the WHO grading system for their priority. And then second in priority would be our L and H, our low and high grade. And then last in priority is the A through D terminology, which again allows you to use the generic grade table. Grade pathological cannot be blank. You assign the highest grade from the clinical or pathological time frame. If you have a resection with no grade stated, use the clinical grade, or a resection with no residual, use the clinical grade. Code grade 9 when the grade is not documented, no resection of primary site, neoadjuvant therapy followed by resection, clinical case only, and if you only have one grade and you do not know if it is clinical, pathological, or post-therapy, you will code grade pathological as 9, and also code 9 if the grade is not marked not applicable on CAT. Grade post-therapy is left blank unless if this is a neoadjuvant case followed by surgical resection, then you would code the grade from the surgical resection. Assign the highest grade after the resection following neoadjuvant treatment. The grade is coded 9 when if the grade is not documented, or there is no residual disease, or marked as not applicable on CAT. Our SSDIs. For peripheral nerves, we only have one SSDI, and that is bone invasion, and this is based on imaging by MRI or CT. It is required by this SSDI for peripheral nerves is required by SEER and COC. For intracranial gland, we don't have any. Just remember that our lymphovascular invasion code is always coded as the default code of 8. Brain and CNS other, we also have our lymphovascular invasion coded as the default code of 8. We have brain molecular markers, which is required by SEER and MPCR. This applies only to the codes named here. If a histology is not one of the included histology on the list, you will assign code 85 if it is a malignant CNS tumor, or code 86 if it is a non-malignant CNS tumors. These histologies will appear in the instructions for this SSDI, as well as in the table themselves, which you will see right here. Our next SSDI is the chromosome 1p loss of heterozygosity, and this is also required by SEER and COC, and this is a molecular diagnostic test performed on the tumor tissue to identify loss of genetic material. Other terms for loss of heterozygosity include whole arm loss, gene deletion, and allelic loss. This is collected regardless of histologic types. The common histologic types are listed in note 4. So if the histology that you have in your case is not listed among those for which the chromosome 1p test is commonly done, and the test is not readily available, assume it was not done and code 9 for unknown. Code 6 for your borderline benign tumors. And note that for this test, the subsequent test for the SSDI chromosome 19q, which will be the next SSDI, they may be performed in the same, they may be in the same report or on the same test. So if you get a report back, be sure to look for the findings for both of these SSDIs, chromosome 1p, loss of heterozygosity, as well as 19q. Here is the table for 1p, and then we'll move on to the next SSDI, chromosome 19q, which is also required by SEER and COC, and the instructions are all the same as they were for chromosome 1p, so I won't repeat those here. And again, here's your table. And then our next SSDI is MGMT, which is collected by SEER and COC. I'm not going to say that long tongue twistery word, but it is an enzyme in cells that repairs DNA. DNA repair is undesirable in tumors because it may enable them to overcome the DNA damage done by chemotherapy. So if the enzyme is methylated, then less of the enzyme is produced, which may lead to prolonged survival compared to unmethylated MGMT. So you're looking for the enzyme MGMT, and you're looking to see whether it is methylated or unmethylated. You collect this regardless of the histologic type, and see your notes for the most common histologic types. And if your histology is not listed among the common histologies for which the test is done, and the test is not readily available, assume it was not done and code 9 for unknown, and you code 6 for borderline or benign tumors. So here is the table for that. Moving on to EOD primary tumor for malignant brain CNS. As I described before, the tentorium cerebelli is essentially the landmark in the brain that separates supratentorial and infratentorial sites. The infratentorial sites are C710, the hypothalamus, the pallium, the thalamus, and C716 through C717. The supratentorial sites are C710, except for the hypothalamus, pallium, and thalamus, C711 through 715, C718, corpus callosum and tapetum, and C719, anterior cranial fossa, middle cranial fossa, and suprasellar. Now, I noticed when I was putting together this presentation that the site for posterior cranial fossa C719 was not included in these instructions. So I did send a question to SEER about that, and they responded back that posterior cranial fossa C719 is an infratentorial site, and they will update that in the next revision. A midline shift is not the same thing as crossing the midline. So in order for a tumor to meet the criteria of code 500 crossing the midline, it must be specifically stated as crossing the midline. And discontiguous spread, including circulating cells in cerebrospinal fluid, is coded in EOD METs. Always code 050 for benign or borderline CNS tumors. And I meant to mention too, in regard to infratentorials and supratentorial sites, it's kind of important for you to understand the distinction for those in the event that you have a single tumor that it extends either infratentorial from an infratentorial site to a supratentorial site or vice versa. That's going to make the difference as whether you code 100 or 500 in the EOD, or whether you code localized or regional in summary stage. EOD regional nodes for malignant brain CNS, we don't have to worry about that. We code 888 as a default code, not applicable. So we can celebrate a little bit there. For peripheral nerve primaries, you need to refer to the appropriate soft tissue schemas. For EOD METs for brain and CNS, the coding structure is the same for brain versus CNS other and peripheral nerves. So we have 00 for none, 10 for distant lymph nodes, 70 for all other metastatic combinations, and 99 for death certificate only. For summary stage, if you're coding extent of disease, then summary stage is derived. Summary stage is histology specific. Some histologies apply to other schemas, so you need to be sure to read the instructions in note 2. Assign code 8 for benign or borderline tumors. Code 0, 3, and 4 are not applicable for brain, CNS other, or intracranial gland. The following sites coded to C710 are infratentorial: hypothalamus, pallium, thalamus. Supratentorial sites that are coded to 718 are corpus callosum and tapetum. Supratentorial sites also include anterior cranial fossa, middle cranial fossa, and suprasellar. Posterior cranial fossa is infratentorial. Midline shift is not the same thing as crossing the midline. The tumor must be stated as crossing the midline to meet the criteria for regional code 2. Read the tables closely if you are not directly directly coding and not coding EOD. A few treatment points: do not record stereotactic radiosurgery, gamma knife, cyber knife, or LINAC radiosurgery as surgical tumor destruction. All of these modalities are recorded in radiation. The brain and CNS other, some surgery code points. Code 20, we code the stereotactic biopsy as surgery code 20. Code 21 is for subtotal resection. This should be the most frequent code, as it is rare that all of the tumor is removed. Code 30 for gross resection of tumor. Code 40 and 55 codes should be rare, as these are your lobectomy codes. Code 40 is for a partial lobectomy, and code 55 is for a total lobectomy. Code 22 is for resection of tumor in spinal cord or nerve, and codes 30 through 55 are not applicable for spinal cord or nerve primaries. The intracranial gland and peripheral nerves have separate surgery codes, so be sure you're using the correct set of surgery codes for those sites. For our systemic therapy, be sure you are utilizing SEER RX for your correct systemic drug classifications. Immunotherapy is being increasingly used. And I've provided the link here to SEER RX, which is also available on the SEER website. For radiation, stereotactic radiosurgery and gamma knife are very common techniques. Do we have any questions?
We do, Robin. First one is summary stage 2018 brain CNS slide will need to be updated by SEER in regards to the posterior cranial fossa that you mentioned in the prior slide as well, correct?
Correct. And I don't even know if that's going to get updated in the newest next version, because they've already updated that. So you may not see it in until the next update, but I did send a question to SEER about that, and they did clarify that posterior cranial fossa C719 is an infratentorial site.
Okay. Has the book Data Collection for Primary Central Nervous System Tumors for 2004 been updated, and is this book still used?
You should not be using, no, I know what book you're talking about because I trained on that book, but it is a little obsolete for tumors diagnosed in 2018 going forward, and you should prioritize the solid tumor rules over information in that book.
Last night I could not find grade manual version 2.0 on that NASER site.
Okay. Let me show you really quick how to do that, because I do want to have, I tell you what I would rather do. I would rather go through our case scenario,
Okay.
and then if we have time, I'll show you how to do that. But essentially, I believe when you're on SEER RSA, there's a place on there where you can click the current version or the new version, and you can select it. But we'll take a look at that if we have time after we go over the case scenario. But I want to be sure I get through the case scenario in my allotted time.
Okay.
So looking at our case scenario, I hope you all had a little bit of time to look over that. But I have gone through and just kind of highlighted the points in the scenario that are relevant to our coding of the case. So we have a child who presented to the reporting facility for an MRI because of headaches and dizziness. So on 3/5/19 at the reporting hospital, the MRI identifies two large, locally aggressive, discrete masses centered along the left acoustic nerve and the left side of the hypothalamus, most suspicious for multifocal malignant glial tumor. So there is our diagnosis date as well as our first contact date. And we are also given sizes for these tumors. The tumor in the hypothalamus is 10 millimeters. The tumor along the left acoustic nerve is 18 millimeters. So on 3/7/19 at the reporting hospital, we have a stereotactic biopsy of the left cerebellopontine angle tumor. Now, this is a very common location descriptor of acoustic nerve. So the op report identifies again the two tumors in the left hypothalamus and the left acoustic nerve. And there's a statement, macroscopic tumor remained after the procedure to avoid nerve damage. So we have that only the acoustic nerve tumor was biopsied and that residual tumor remained after the stereotactic biopsy. Our path findings were ependymoma, RELA, fusion positive, WHO grade 3. So the patient meets with the medical oncologist who states, due to the similar appearance of each tumor, we're assuming histologic types and WHO grade are the same and will treat both as RELA fusion positive ependymoma, WHO grade 3. We'll proceed with chemotherapy consisting of etoposide, bleomycin, and cyclophosphamide with concurrent radiation. So there you see the plan for multi-agent chemo with radiation, which began on 3/25/19. And here we have the treatment summary with our starting and ending dates, and specifically saying that the treatment was given simultaneously encompassing both primary tumor volumes, and that the patient completed treatment as planned. Our follow-up MRI was negative for residual disease, and then our follow-up med-onc visit notes that the patient had a complete response to chemoradiation, and they will monitor every 6 months with possible salvage surgery upon progression. So let's look at our answers. So the first question we have to answer is this multiple primaries, yes or no? And the answer is yes, because of M8. Although you have two tumors with the same histology, they are in two different subsites of the central nervous system. We have one in a brain subsite and one in a cranial nerve subsite. So one is the C724, the left acoustic nerve, that is a cranial nerve subsite, and the other left hypothalamus, that is a C710 subsite. That's a brain subsite. So we do have multiple primaries here. Our date of first contact is 3/5/19 per the MRI. And I want you to notice in this rationale documentation column that I have provided the manual and the page number in the manual for your reference for instructions on how to code these data items. We have sequence number 1 and number 2 because these are both malignant primaries. We coded the acoustic nerve primary as sequence 1 because it was the larger tumor. And then the hypothalamus primary is sequence 2. Our class of case is 14. The diagnosis and all first course treatment was at the reporting hospital. The date of diagnosis is 3/5/19 per the MRI. The primary sites are C724 for sequence 1, acoustic nerve, and C710 for sequence 2, hypothalamus. The laterality for both is 2 for left. The histology is 93/96 for RELA fusion positive ependymoma. This is per the biopsy and our histology table in the solid tumor rules for malignant brain CNS. Our behavior is 3 for malignant. The diagnostic confirmation for sequence 1, the acoustic nerve tumor, was 1 for the positive histology. The diagnostic confirmation for sequence 2 is 7 for the radiographic confirmation. Clinical grade for both is 3 for WHO grade 2. We do not have TNM staging, so we code those as 88. Our pathologic grade is 9 for both because there's no surgical resection. The stage group for both is 88. We do not have TNM staging. And then we can skip down to tumor size clinical is 018 for the left acoustic nerve tumor and 010 for sequence 2, the hypothalamus tumor. Tumor size path is 999 for both as no surgical resection. Tumor size summary 018 for sequence 1 and 010 for sequence 2. The sentinel lymph node biopsy codes we can leave blank as these do not apply for these primary sites. The date of regional lymph node dissection is 0s. Regional lymph nodes positive and examined are 99. These are the default codes for these primary sites. Lymphovascular invasion, 8. These are the default codes for these primary sites. And all of our METS fields are coded 0s as we had no indication of METS in the case. Our summary stage is 1 for both, localized. There was no mention of extent beyond the named structures. EODT for both is 100. Again, no mention of tumor extent beyond the named structures. EOD regional nodes is 888. This is the default code for both of these sites. EODM METS is 00, no mention of METS. SSDI brain molecular markers is 85 for both of these sites because this histology for this case was not one of the named histologies for this SSDI. The SSDI chromosome 1p and 19q status are both marked as 9 as there's no indication that the test was done and this histology for this case was not one of the common histologies for which this test is done. And same for the SSDI MGMT coded as 9. Date of SEER and COC for, first course treatment is 3/7/19. That was the start date of the chemoradiation. Oh no, I'm wrong. That was the date of the stereotactic biopsy. The treatment status is 1. The surgery of primary site is 20 for sequence 1 and 00 for sequence 2. Now you might wonder, why am I coding the date of first course treatment for sequence 2 as 3/7/19 since the primary site, we did not have a stereotactic biopsy of that primary site. Well, the instructions in SEER tell us to code the date of surgery as the date of surgery was done to the primary site, a regional node, or an other site such as a regional site or metastatic site or metastatic lymph node. So therefore we do code that 3/7/19 surgery date in sequence 2 because we did have the stereotactic surgery of the other regional site, which we collect as code 2 in surgery other regional for sequence 2. So For surgery primary site, sequence 1 is 20 for the stereotactic biopsy. And for sequence 200, our scope of regional lymph node surgery is 9 for both. That is the default code. And our surgery other regional distant is 0 for sequence 1, but 2 for sequence 2 for the other regional site. Our margin is 9 for sequence 1. Although you had a statement that residual tumor remained in the op note, there was no statement in the path report in regard to the margin status. So our instructions are, if there's no statement about margins in the path report, to code as 9. For sequence 2, we record that as 8 because there's no surgery to the primary site. Our radiation sequence is 3, as radiation was given after surgery for both primaries. Our treatment summary chemo was 03 for multi-agent chemo for both sites. The rest of the systemic fields are coded as 0s. Our systemic sequence is 3 for after surgery. The reason no surgery is 0 for sequence 1 because we had the stereotactic biopsy to the primary site, and 1, no surgery. This data item is for surgery to primary site only. So that is why we code these two differently. And then here, these RX HOSP codes, these are going to be the same codes as our RX sum codes. So we can skip down to reason no radiation, coded as 0s because radiation was given to both primaries. The start date 3/25/19, the end date 5/1/19. The radiation location is 1, given at the reporting facility. The number of phases to each primary site is 1. Discontinued early is 01 because the treatment was stated completed as planned. The total dose for each is 5,000 centigrade, coded as 005,000. The volume for each is 13, partial brain. Radiation to draining nodes is 00 for each. The treatment modality is 02 for photons. The technique is 05 for IMRT. The dose per fraction is 00200 for 200 centigrade. The number of fractions is 025 for 25 fractions, and the phase 1 total dose 5,000 centigrade, coded as 005,000. Moving on down to our systemic date, 3/25/19, chemo 03 for multi-agent chemo, and the chemo date 3/25/19. And the rest of the systemic fields we code as 0. Do we have any questions? Oh, how do I
Hey, Robin, it's me, Rhonda, and it looks like we do not have any questions other than, will this be available other than in the presentation? And the answer is yes, we will send out the answers. You can send out the answers beforehand because that would defeat the purpose.
Yep. I'm trying to figure out how to exit my share, Rhonda. Oh, here we go. Stop share. Okay. All right. Now, someone had a question earlier about, what was that question, Colleen, about the grade?
Last night, I could not find the grade manual version 2.0 on the NASAR site.
Okay. Let me see. Okay. I think there is a way to do that. Let's see. Let me go back to share. if you go into let's see. Well, let's look at the NACER website first, because that's where it comes from. Central Registry, and you want to go to site-specific data items. Did she say SSDI or grade?
Grade manual version 2.0.
You see here, if you see that I have the home page open for the site-specific data items and grade, you see where I'm hovering over current, and then I'm hovering over 2.0 upcoming. That switches you over to 2.0 upcoming, you know, that to the version 2.0, and then you can click on whether you want the SSDI manual or you want the grade manual, and that will be 2.0.
Thank you.
Mm-hmm.
I don't see any other questions.
We have one.
Oh, we do?
Yes, ma'am. It says, why would you code tumor 1 to acoustic nerve C724
Oh, I see it.
and not angle C716?
The tumor was described repeatedly as acoustic nerve. The cerebellopontine angle is more a description of location, but the I chose the acoustic nerve tumor because it was, repeatedly referred to as an acoustic nerve tumor. We can pull up the case and see that, but I'm not in screen share. Let me get back to share. Okay, here's the case. Okay, so the MRI says it's centered along the left acoustic nerve. And then the op report in the area of the left cerebellopontine angle along the acoustic nerve. And so I went with acoustic nerve. I see a lot of cases of acoustic nerve where when the patient has surgery, there is a description of the tumor being in the area of the cerebellopontine angle. So I interpret this more like the example that I gave, or that was stated in the solid tumor rules about the cavernous sinus, that tumors don't arise in the sinus itself, but along the structures that pass through the cavernous sinus. So I was kind of using that same principle there.
It just states, I was confused because they biopsied the CPA. I overthought things and determined that along the nerve wasn't actually in of the nerve.
Well, like I've said before, this is subjective. This was an actual case. I did not make this case up. A colleague sent me this case a while back, wanting to know if this should be coded as multiple primary or single primary, and I did send the case to SEER, and they told me multiple primaries.
Okay. Nothing else has come in.
Yeah, you are correct. So it looks like we are done for this morning session. Thank you so much, Robin, for your very informative presentation. this afternoon, we have a super fun game that we are going to make this as interactive as possible. Debbie reminded me that there actually is a handout that goes with the game this afternoon, so that will be sent momentarily, so be on the lookout for that. I'm excited. It's gonna be awesome.
Yes.
It's gonna be awesome.
I'm excited too because my hard part's done now. Yay.
Yay!
No, you did fantastic. You did fantastic.
Thank you. And I finished right at 10:30.
You did. So we appreciate you. Ladies, anything else before we let everybody go, and we'll see them this